Welcome to the July edition of the ECG 5-Minute Consult, JEMS' ECG of the month, brought to you by paramedic Troy Kennedy, Dr. Hayden, and myself, where we teach you foundational ECG knowledge using the primary survey approach from our book, ECG for First Responders, available on Amazon. Let's take a look at today's case. You arrive on scene to find a 55-year-old firefighter complaining of chest pain after unloading a fire hose. The pain reportedly began 15 minutes ago, is described as a crushing, pressure-like pain, and is rated as a 9 out of 10 in severity, radiating to the jaw and left arm with no modifying factors. This patient has a past medical history of hypertension and hyperlipidemia, for which he is taking lisinopril and atorvastatin daily. As we examine this patient's ECG in the context of a primary survey, we'll be seeking to answer these 4 questions. First, the heart rate. Is the rate too fast or too slow, causing cardiovascular instability? 2. The rhythm. Is the rhythm supraventricular or ventricular in origin? 3. The ST segments. Are they consistent with an ST elevation myocardial infarction STEMI or a non-ST elevation myocardial infarction NSTEMI? And lastly, are the T waves consistent with STEMI or NSTEMI? So that being said, let's start by determining the rate. Previously, we talked about determining the heart rate by dividing the number of large boxes between R waves into 300. This time we'll demonstrate another useful trick, which is to first find an R wave that aligns with one of the vertical graph lines of the ECG, like this one, just to make visualization easier, and then we'll count boxes until the next R wave appears. However, we'll be doing so by counting in intervals beginning with the number 300. So what I mean is, if we choose this R wave and put our starting line there, if the next R wave happened to land 1 box away, that means the heart rate would be 300. If the next R wave happened to land 2 boxes away, it would be 150. 3, it would be 100, and 4 boxes away, the heart rate would be 75. We can see that our R wave lands just before the 75 mark, so we'll call it about 80, and that is within the normal range of 60 to 100 beats per minute. Now, to tell if the patient is stable or unstable, we'll need a set of vital signs. We can see that this patient is awake, alert, and oriented times 4. They have a blood pressure of 146/92. They're satting at 98% and have a respiratory rate of 14. So since the patient has a rate in the normal range, is hemodynamically stable as evidenced by his blood pressure, the patient can be considered stable, at least for the time being, with no intervention necessary in regards to the rate at this time. By the way, if the rate was slower, by which I mean the R waves further apart, we would continue using this trick, and it would go down all the way like this to a rate of 60, then to 50, then to 43, and then to 37. And that's about as far as we can go using this neat little trick. All right, now that we've determined the rate, let's take a look at the rhythm. For the rhythm, we need to determine whether it is ventricular or supraventricular in origin. As we've discussed in previous cases, supraventricular rhythms can be dangerous if sustained or in the context of STEMI or NSTEMI. It's important to delineate them from ventricular rhythms, as ventricular rhythms can inherently cause hemodynamic instability and or devolve into VTAC or VFib. To determine the origin of this rhythm, we'll take a look at the QRS complexes. They all seem to be preceded by P waves, and if we look closely at the width, we can see that our QRS complexes appear to be less than 3 small boxes wide. And remember, if a QRS complex is less than or equal to 0.12 seconds, or 3 small boxes, it is considered narrow or normal, versus a QRS that is wider than 3 small boxes or greater than 0.12 seconds. That would be considered wide or abnormal. So since we have narrow complexes preceded by P waves, we can tell that this is a supraventricular rhythm. Additionally, the QRS complexes are equidistant, indicating that the rhythm is regular. Because this is a supraventricular rhythm in a patient with stable vital signs, no intervention is necessary regarding the rhythm at this time. However, if this were a ventricular rhythm, you must be prepared to intervene immediately following ACLS guidelines should the patient's condition deteriorate. For example, if there was a drop in blood pressure, or the rhythm changed to ventricular tachycardia, or worse yet, to sudden ventricular fibrillation. Next, we will have to examine the ST segments to see if they fall in the same plane with the isoelectric line, that is the baseline, looking specifically for elevation that would indicate infarction, which is the death of myocardial cells, or depression, which could indicate ischemia, inadequate blood supply, or infarction in the case of a non-ST elevated myocardial infarction or NSTEMI. which we would need cardiac enzymes to confirm, so don't worry about it in the field. The receiving hospital will determine that. Suffice it to say, if you see evidence of NSTEMI, it's best to consider it so until proven otherwise. For our ECG, it looks like there's some significant elevation in the high lateral leads 1 and AVL, as well as anterior lead V4 and low lateral leads V5 and V6. Additionally, there seems to be reciprocal depression, essentially the mirror image of the ST elevation, in inferior leads 2, 3, and AVF, septal leads V1 and V2, and anterior lead V3. Now, we will look at the T waves. We know that T waves should be upright in all leads except for AVR and V1. On our ECG, the T waves appear unremarkable with the exception of 3 and AVF, which may be biphasic, but it's important to note that it's not possible to evaluate T waves adequately in the context of distortion from ST changes. With the primary survey complete, you have determined that this patient is probably having a lateral wall MI, and you begin to get him loaded into the ambulance. He's still on the cardiac monitor, and a new set of vitals show a BP of 140/88, heart rate of 84, SpO2 of 99% on room air, and he's rating his pain as a 9 out of 10 in severity. What should you do next? And keep in mind there may be more than one correct answer. Should you A, place a nasal cannula and administer oxygen at 2 liters per minute? B, notify the base hospital of a STEMI alert? C, administer nitro 0.4 milligrams sublingual? D, administer atropine 0.5 milligrams IV? Or E, transport to the nearest hospital with percutaneous coronary intervention PCI capability? The correct answers are B, C, and E. Let's take a look at all the answer choices together. A is incorrect as the patient is already satting at 99% without oxygen. Studies have shown that routine administration of oxygen to patients that are not hypoxemic is not beneficial. B is correct because you would want your base hospital notified as quick as possible to put in motion the steps of cath lab activation that will be necessary for this patient upon arrival. C is also correct because the patient is still complaining of severe chest pain and he is still hemodynamically stable. D is incorrect as that would be the treatment for symptomatic bradycardia, which is not the problem with this patient. E is correct as you would want to transport this patient specifically to the nearest hospital with percutaneous coronary intervention, PCI, aka a cath lab, even if it means bypassing a closer hospital that does not have the capability of receiving STEMIs. That's all for today. We hope you've enjoyed this edition of the ECG 5-Minute Consult. If you'd like to learn more about ECG interpretation, check out our book ECG for First Responders on Amazon. Thanks for your support. We look forward to seeing you next month.